I apologize for the title and the Buzz Lightyear reference. I come from a department that likes a lot of catchy titles. And when I was invited to speak, I was really had to talk about a grab bag of SBRT, which is hard to make into anything interesting. So I have no disclosures with respect to the content that I'm going to be presenting today. I do want to preface it with, I am a radiation therapist, so I'm going to be providing you really with a practical perspective of implementing these techniques. You've heard throughout the last 2 days a lot about the evidence and the clinical rationale. I'm not going to make necessarily comments on the clinical rationale, just speak about how we have gone about implementing these techniques. So the objectives of my talk, I'm just going to describe the stepwise evolution of our SBRT program at Odette, and a little bit about the requirements to ensure that the quality and safety of treatment is always maintained when you're expanding to sites. I'm not so much going to focus on illustrating through case examples. There will be some mentioned throughout just to weave in a little bit of context, but otherwise I would have been up here for much longer than intended. So just to set the stage of where we come from, and this applies to William, who's just speaking, this is Odette. So we're from the Uptown Center, as we say. So it is actually a very, very large academic center as well. So we see 20,000 new patients a year, over 7,000 RT patients, and in a day we treat over 300. So context of the technology that we have, we are a full Electus site at this point, and it's sort of important when you think about your implementation and what you can do with your techniques. So we have 12 linear accelerators, depending on how many we're replacing at any one time. We do have the Gamma Knife Icon unit. There's an orthovoltage for skin. We have a very large HDR-LDR brachytherapy program, and a 1.5 Tesla MRI sim that is integrated fully into our brachy suite. We also recently gained access to a 3 Tesla sim that we have part-time access to, and then we have we're in the middle of commissioning and upgrading our MR Linac to the clinical system. So really, I just want to start, and a lot of this expands on what Dr. Bisanat talked about yesterday, is just what is really required for the safe delivery of SBRT. And there are actually really great guidelines that have been published that outline this. And I've referenced two. One is Arjun Segal, and this is the CARO guidelines, as well as the AAPM TG 101. And both of those documents really outline everything that's needed in order to ensure that you're doing this safely. Because as we've heard over the course of the 2 days, there is the possibility that you can harm a patient. So really from the programmatic perspective, you need to establish the scope of your program, and that includes what treatment sites are you going to be doing in the clinical goals. You really don't want to be doing this ad hoc and making it up as you go. Obviously, the technology is important. You need to ensure that you can deliver this safely. So you need the advanced treatment planning that can handle the small field geometry and the delivery systems. We want small MLC to make sure you can have that conformality. As well, ensure appropriate education and training of the multidisciplinary team, and that is everybody involved in the team. So we have a very large center. Not every one of our radiation oncologists does treat with SBRT because they don't necessarily have the expertise. And when we have a new oncologist want to move into one of the site groups, we have a very annoying sort of orientation they must go through. But you need to ensure that everybody who is part of the team knows what they're doing. And certainly certain physicists specialize in certain disease sites, and even to the therapy level. Our SBRT patients are treated on dedicated teams. And then I put in their continuous program evaluation. You may implement a technique, you can't say, okay, we're done. There's always room for improvement, and you need to keep looking at what you're doing. So just in terms now, a little bit more micro. So within a disease site, you need a very robust simulation and target definition methods. And some of the things that you need, one, obviously, I didn't put in there, but thin slice CT. You can't have 5 millimeter CT slices when you're going to be treating really tiny targets, right? We need to make sure that we're defining exactly what we're treating accurately. So that could involve multimodality imaging for both target and OAR definition or delineation. And as well, really important is assessment and appropriate management of any tumor motion. For the treatment side, image guidance is everything. So we want to be able to see what we're treating to make sure we target it. And I'd say establish very clear protocols and then make sure the education is appropriate. And as well, in every step of the way is rigorous quality assurance. So certainly from the physics side, acceptance testing and end-to-end, but I'd say really valuable is peer review QA. So from the beginning, we've always had our own dedicated SBRT QA rounds. And when we were a smaller program, every SBRT plan would be reviewed there. Sort of as each anatomical site has gained experience, they've moved off to their site-specific, but we still maintain for the lesser experienced ones to make sure that every plan has a good look at before we treat them. Okay, so this is a little snapshot. So you just heard in the talk before that prostate SBRT did start before this, but at the time it didn't call itself SBRT, so I still like to start the clock for our true SBRT in 2008. So we began with lung and spine, and then liver followed closely in 2010. Also in 2010, we opened a phase 1 study looking at the treatment of oligomets, so we expanded into a few sites. So this is just a snapshot into the future. We won't dwell on it, but you can see it goes fast and furious awfully quick. In 2012 is when I started in my role as a clinical specialist therapist, which is an advanced practice role in the program. So I am not responsible for what happens after. I was there more to help manage it, just to say. So just a quick context, my role has an element of clinical, technical, education, and leadership. One of the things in the technical side is to standardize treatment protocols for all sites of SBRT. I am in the unique position where I actually sort of see everything. So I can help knowing, okay, the liver site's been doing this, this may help somebody else. So I have a very interesting position in the program because I do touch sort of every point of SBRT. So I can't really tell you how we've evolved until I give you a little bit of where we started. So this is, I'm not going to give you very many details, just little snapshots of how we evolved. So spine is led by Arjun Sagal. So the standard immobilization, same as what we heard yesterday, is the body fixed dual vacuum system. We use also the 5-point ORFIT, but for any T4 and superior. So the common dose fractionation schemes we use now are 24 to 28 and 2, or 30 gray and 4, treated daily, same as yesterday, the PTV margin's 2 mils. So very, very small PTV, extremely sharp dose gradient right at the spinal cord, so you need that near rigid immobilization. We do have MR simulation for cord, and yes, daily cone beam with hexapod robotic couch, so 6 degrees of freedom correction. I will say we have 4 hexapod units on our electives, so we use it a lot. Is it necessary? Not for everything, but we have them, so we use them, so I'll just say that. But for spine, I think it's very beneficial. So okay, I should also go. Not very much has changed with spine since it was introduced. We have, with basically some improvements in technology, mostly in the speed of delivery, with being able to plan some VMAT, and with FFF, we do sim some patients' arms up because therapists really don't like treating the arms. I know it's okay, but we just can't get past it. But it was a long fight with Arjun, and really it has to do with, you can imagine, originally it would take an hour to treat these patients. An hour is a very long time to make someone hold their arms up. They get uncomfortable. But now that we've coned it down so short, some patients have their arms up. Really only for the lower L spine and S, but that's about the biggest change we've made. In terms of image guidance, to me this is as simple as the clip box is one vertebra above and below. It's a bone-to-bone match. Either it's perfect or you don't treat. It's a very simple decision-making. So for lung has gone through some evolution. So it was all starting at the same time, so we started our lung in the body fix. The lung body fix is even sort of more difficult to use than the spine because it's this half poncho sort of thing. It was very cumbersome. I actually worked in simulation through all this, so I know lots. So we used the body fix. We had 3D conformal planning in the very beginning, 48 in gray and 4 or 50 and 5, delivered twice weekly or every other day. Quite early on into it, we realized this was not a great option in terms of resources. So Kathy Hun, who's now a radiation oncologist here, this was when she was a resident, with Patrick Chung, we did a trial comparing body fix to abdominal compression to free breathing, and found that the abdominal compression reduced the supinf motion and overall motion better than body fix, and it was preferred by all patients. But we had the data. We looked at the data to make sure, yes, this is a good move forward. So we did move to using abdominal compression for every patient. I will say, because it's such a high volume center, we have never been able to have a good way to assess motion up front to see if patients need it. So for in lung, they all get abdominal compression. So we did also transition from using the big back bag to a board, a chest board, similar to what we've heard here. And that was evaluated in terms of reproducibility and interfraction motion. Again, really on resources. If you get a hole in these bags, you have to replan everybody. It's quite annoying. Another, when you start to have the volumes we were having, storage is a massive issue. So we moved to a board still with abdominal compression. And with the board, we found there was no difference. It actually, the setup accuracy was better because you could rotate and move patients a little bit better and position them. And there was no difference in the interfraction motion. So this is what our lung protocol is now. We use the board with abdominal compression. The dose fractionations have changed a little based on some of the outcomes we found. So we go up to 60 and 4 for colorectal mets, and we may go down, and that has to do with going a little bit more centrally. Still 4 DCT. We do have FFF, so things are a bit faster, but otherwise, this is how lung is treated. And lastly, IGRT, I should say. So really, it's a soft tissue match. We match the ITB. When we say that, it doesn't mean we ignore the organs at risk. They're certainly evaluated as well. But we don't start with a bone match and then zero in because we can correct for rotation. So it is a tumor-to-tumor match. So in terms of liver is, I still believe, one of the probably the most challenging site. Dr. Chu can comment later. So this has actually been the program that we've had the greatest evolution, and I'll just talk a bit about it. So again, at the same time as spine, so we start with body fix, because that's what we knew, that's what we did. And then we were MRT, luckily we had VMAT, so that's going to start to make things shorter. And then sort of piggybacking on the lung experience, we thought, okay, well, what can we possibly use this abdominal compression for liver instead? So what we did at that time, and this is something I presented in Caro, is just to look at, from ourselves, from a resource point of view, how is this going to impact the time at each step that the patient goes through this? So this is just a snapshot of the sim data. Not surprising to anyone, patient-simulated abdominal compression had a reduced setup time. So this is 7 minutes shorter. Not apparently statistically significant, but 7 minutes in a sim appointment is a lot of time. For treatment, so there's obviously 3 different groups: the body fix with the IMRT, body fix with VMAT, and then those with abdominal compression. So it's good to know that there was an improvement in each step of the way. So when you obviously, not surprising, from IMRT to VMAT was faster, but still going from body fix to abdominal compression made it even faster still. So we're going in the right direction in terms of treatment. But then you also have to consider the planning time. A lot of this, I would argue, has to do with the learning curve, but at the time when we first did this, there was a significant greater, and I think our computational power wasn't quite as good then, but also something to consider. There's going to be a trade-off somewhere in whenever you're making changes to your technique. So I will say now, the one thing you cannot argue is the gains that you can get if you can take the motion out of it. So we have also implemented an ABC breath hold technique because it just makes the pictures, the images so much better. You're so much more certain about what you're treating. So we currently have FFF with ABC, but that ability to move to VMAT and FFF reduces the treatment time so that we can do this, and we haven't lost so much on time. So, and in terms of IGRT, liver is the most complicated. We've heard throughout about having respiratory sorted cone beam. We don't have that. So we don't have, which I think is a nicer option. We don't, so we have, where somehow we have to be able to assess the motion. So we have a contour that represents the 0 or the inhale and the 50%, which is the exhale. And so we make sure the liver's within there and match liver to liver because you usually can't see the target. So, as I said, then everything starts to grow. So this just gives you a snapshot of how the program has gone since 2011, which is after the liver introduction, and the different sites and how much the sites have grown. So not surprising, the very first new site that we see is non-spine bone, because that's relatively simple, or so you think. So if we're thinking about treating non-spine bone, there's lots of things we need to consider, and a non-spine bone can be found in lots of locations. So there's the mobilization, or how you're going to sim. So I sort of broke them up into what locations we expect. So rib, we can really draw on our lung SBRT experience. It's in the thorax, so you could think there's a lot of things that are similar. Hip, femur, pelvis, okay, spine maybe, because similar to sacrum. The shoulder, girdle, well, maybe spine, we'll think about C-spine. You'll see I've left extremities off of those. Those are a whole other area to discuss. And then the same for the planning and the image guidance. We've had experience with the sites we were already treating that we could draw on to best come up with a way to treat these. So immobilization, so okay, we're body fix happy already, but there's the question, is that level of immobilization actually required when you're treating something like a pelvic bone met? So as Mel was deciding, we do post-cone beams for any new type, so it was proposed we probably don't have to vacuum seal those patients and make them really uncomfortable, you know, if they're in a nice firm bag. And we evaluated the post-cone beam to show that, yes, they don't move. We don't need to put them in a vacuum, which saves a lot of time and makes the patients more comfortable. The other question is for ribs. Well, do they move? Because they are part of the thorax. How much does a rib motion move, and do we need to? So from the start, we've done 4D CT as a standard, but we've never really evaluated it because it does take a while to get enough patients to have a sense. So this is just a plot of all the patients that I evaluated against the linear distance, and just to remind you what the equation is. So the problem to me is we need to identify those top ones because that is a lot of motion, and if you didn't account for it, you're not going to be treating your target accurately. So then what I did, so this was done in Pinnacle, and I used the auto contour tool to try and take away any subjectivity. So if you can imagine, if this is an axial slice, I sort of grouped where the lesions were, whether it was anterior, lateral, or posterior, thinking, you know, probably a posterior isn't going to move, and then tried to find if there was a difference, and it is approaching significant in posterior. And as well did that for the sup and nymph to see if we could isolate which parts of the ribs are going to move and require 4D. So I have worked on updating this with greater value, and hopefully we'll write it up at some point, and this is going to inform our protocols. Doing 4D on everyone takes a lot of time, and it does expose the patient to more dose, so if we can eliminate it, good, but at the same time, you don't want to miss any motion that there might be. Okay, so William spoke a bit about CROP, which is our oligomets trial for prostate cancer. So this is just an example of a patient who was accrued to PROP, and the plan was to deliver 35 and 5, and there's 2 activities on the bone scan on the sternum. So the patient is an outside patient, came with the CT. You couldn't really see on the CT where the lesions were. Obviously, the CT sim wasn't that great. We can see this one, but the physician ordered an MRI. So you can see it's an outside MRI, which this could also lead to discussions about the benefits of MR sim and having a bit more control, but we don't. So the MRI helped delineate the two to where the 2 lesions were. This is just a sample of the plan, so it showed where we're going to treat. So this was starting to happen a little bit more often, where in bone met patients, you know, sort of coupled on the spine experience, where the physicians were ordering MRI to help with target delineation. So we did do a study to look at, okay, what is the impact of using the MRI to help define the target for non-spine bone? So this was 10 cases were contoured by 6 different radiation oncologists, and they were all the radiation oncologists that at the time were treating bone SBRT. So the dice coefficient was the lowest in the CT alone, and you can just, like, this top one, you can see how different all the contours look. And it was significantly increased with the addition of T1 MRI. It's not really surprising, but you might not think. Some people think treating a bone is so simple. Well, if you're going to target it that accurately with a high dose, maybe you do need to incorporate MRI as well. So this is sort of our current bone SBRT guidelines where we've come to. So based on a spine experience, if it's really small and away from everything, there is still a 2-fraction option, as well as a 5-fraction, which really falls in line with the rest of our protocols. There is the option for MRI stimulation, so we have all those that whole protocol outlined. The PTV, we have never been able to get them to agree to an exact standard, but somewhere between 3.5 and 5, and that depends on immobilization, organs at risk, a few things. And VMAT, but treated daily. So this is where we got to, but there was a lot of work that went through to inform to get to this. And the IGRT, also very simple. There's not much that you need to, I mean, again, it's a bone-to-bone. In terms of the clip box, you obviously want to cover the whole PTV, but in an area enough that's going to give enough information for a good automatic match. I've added this, we saw this picture in the last talk, but just to say, in the CROP study, we do have circumstances where we're treating the prostate at the same time as a bone met. So if there is quite a bit of distance away, like for example, if this was up treating on the iliac crest or something, we may add an additional margin to the bone, because we already said, you know, the prostate may deform, may move slightly, and we want to make sure we target that exactly, but then have a little bit of extra wiggle room on the bone. And I think it's really important that you do look at your outcomes of your techniques, especially when you're introducing new sites. So I published this earlier this year in the Green Journal, and it was just a review of our experience with non-spine bone, because there's very little that's been published in the literature about it. So basically, sort of like everything else, it's quite effective. The local cumulative incidence of local recurrence was 4.7, 8.3, and 13.3 at 6, 18, 24 months. There was a significant association between local recurrence and PTVs, so the larger PTVs were harder to control, also fairly obvious, but fracture also was it wasn't as significantly higher, because, sort of thinking, are you going to find new toxicities like sort of happened in bone or spine when they had increased vertebral compression fractures and pain flare? So the future work, and we had this talk with Dr. Hope yesterday, just looking at response assessment. So similar in bone, strange things happen after SBRT, and this is just a paper that one of our med students published, just actually describing what you can see post-SBRT in bone. So it's something that needs to be worked out. The other is, what is the impact on the joint? There's really no contemporary data on joint, because most of the data you find now is from old sarcoma literature. And then we want to further integrate MRI. Okay, so the next, and Dr. Wong spoke a bit about adrenal metastasis in primary kidney, and we have more experience on this, so I will talk about. So again, the implementing of this. And again, using the same buckets, really we had our liver SBRT experience to draw on. I know the liver and the kidneys are very different organs, but we're still working in the same part of the body. There's motion issues with adrenal and kidney, so that's what we drew upon. So a simulation early on in our work, one of our physicists documented to see how much the kidneys move. So this was published. So they can move in some cases. This doesn't show a lot, but obviously SUPIMP is the most and can be up to 1 centimeter. There were patients in this series that moved up to 2 centimeters. The other interesting thing is they move in a very strange way when they move. They rotate and sort of rock. So it's something that you have to get used to looking at. So again, then I should have prefaced it, yes, we started with body fix because we start everything with body fix. But then we learned in kidney, if you try to use the arch, our arches, we've had an abdominal compression, we've moved to an in-house model, and you can see there's areas of high density, so the physicists do not want you to put beams through there. And inevitably, just what happens, abdominal compression tends to move everything sort of posterior and sup, but it just seems to perfectly happen that the kidney falls under those high density lesions. So this was our lesson. Well, we can't really, just without compromising possibly what the dosimetry is going to look like, we can't transition to abdominal compression. So we have remained with body fix for kidney. The other interesting is for the organs at risk. So kidney, and Ali talked a bit about it, that there's not a whole lot of great data on the tolerance. Well, there is old data on the tolerance of kidney, but in this realm of SBRT, what do you do with the kidney? And even more so, what do you do when the kidney is actually the target itself? So what we've adopted and trying to do is that we contour the kidney parenchyma, so the cortex, separately, because that's the functional part, and then define the hilum also on its own, just to investigate any hypothetical link to renal hypertension. But it's just something you need to think about to look at things a little bit differently when you're introducing new techniques. So this is where we are standardly. The kidney, again, still in the body fix. Abdominal compression we can use for adrenal. They hit, because they're superior, they tend to just be nicely outside of where we can't go. We do 4D CT to account for motion. The PTV is 5 millimeters. Our dose fractionation ranges from 30 to 45 and 5 and treated every other day. And there's a couple of examples just to show you. For the image guidance, again, it's soft tissue to soft tissue. Because there can be a lot of motion, especially with the kidney, we do have a 0 and a 50 kidney contour that goes over just to help with that. And we really try to also teach the therapists that it's not just the target. The kidney is also the most critical structure, even that kidney that it is, and the same for the adrenal. So the kidney match is absolutely crucial as well. And a little bit about outcomes. So Joe Chang, who's one of our fellows, published up our initial experience. So these are the first 16 patients. This is the spider plot showing response. The one thing you also know, also from Dr. Hope's talk, some of them grow first. So they're growing, and then they shrink, and then they grow. So again, response in kidney is another thing that has to be evaluated. But really, the local control, short term anyways, is really, really good. We did have, and I will say, the 2 grade 4 renal toxicity, so patients who already had quite significant chronic kidney disease, they did require dialysis. The argument was their tumors in both cases were growing quite significantly, and likely the tumor burden was going to result in that anyways. And some more, this is also one of our super fellows, Mark, who's now left to sit Durham, but looking more for trying to predict this late renal toxicity. So looking at more of our patients, 52 patients, and the mean change of the GFR was it did decrease by 6.3 mils, and the uninvolved renal cortex was the only dosimetric feature related, and this was interesting, that patients with more than 1 centimeter of tumor motion were also at a higher risk, so just something. Again, highlighting the need to continue to evaluate what you're doing. And I'll skip over this because Dr. Wong did talk about the IROC, which Dr. Chu was lucky to contribute data to this. I'll just say that. So future work for kidney and adrenal, we have, we just accrued the last patient to our Aquos RCC trial. So this was a prospective trial assessing the quality of life and outcomes in patients treated on this for primary RCC. So hopefully this will really help. I think quality of life, patient-reported outcomes is something we maybe haven't spoken enough about in the last 2 days, and that's another really, really important thing to evaluate when you're doing these SBRT techniques. Based on that finding that the patients with greater than 1 centimeter motion may have been at higher risk of toxicity, we're going to try and develop a breath hold technique with keeping in mind something that's reasonable in terms of resources based on, this is not a huge patient number, but we don't want to make it too resource intensive for the therapists at all. And then further integration of MR. Okay, so lymph nodes. So lymph nodes can mean just about anything, and then so I've sort of placed along where we draw upon everything. So cervical and supraclav, we do treat similar to our head and neck SBRT. I am not touching that today. I feel it's out of their scope, much to the chagrin of Ian Poon, but we do it. I defer you to some of our head and neck literature. We do also have treated a few mediastinal and hilar, which based on lung, and I will touch on that a bit, is scary stuff, and then the abdominal and pelvic. So mediastinal and hilar, really, we do everything the same as if it is a lung. The one thing, the IV contrast may be more helpful for target delineation. The IGRT, it is absolutely critical for the therapist to make sure they assess the organs at risk for this. So at this point, we pay very close attention to these. It's not just a target to target. You need to make sure everything is lining up. So this is in press. It hasn't been, one of our fellows, again, did write up our ultracentral outcomes. And it really was a comparison between central versus ultracentral. And ultracentral is actually touching the main bronchial tree. So there was no significant difference in the local control or toxicity rates between the 2 groups. But on multivariate analysis, having lymph nodes treated was significantly correlated with a higher risk. So this series isn't necessarily all lymph nodes, but they did have a few in there. So I just wanted to put it in, again, to remind you, just to make sure you follow the outcomes to know. And I will say, when we are treating that centrally, it's not 50 and 5. The dose is reduced to 40 and 5, 45 and 5. So it's not like they're using the same doses as standard lung SBRT. It is scaled down to try and be safe in that area. So abdominal nodes for stimulation, patient position and immobilization. I just wrote there, communication is key. Mel may remember this case. So apparently the physician gave them some very different instructions in this because they didn't think they needed arms up. And poor Mel had to create a contour for the IGRT that basically was arms here are okay or arms there to make sure everything was safe. But really, again, for the nodes, we don't use full body fixed compression. We did, again, the post-cone beam shifts to make sure that was okay. So they are usually with their arms up, but therapists always like to be nice to patients and put their arms on their chest if they can. The other thing, again, in the abdomen, and we spoke about this morning, is assessing the motion. So again, I started doing some work looking. We, by default, went to 4D CT for all of our abdominal nodes, again, because you don't want to miss something that moves. So just starting to look at it now, this is obviously a case that moves significantly. Given its proximity to the kidney, you would expect that, and you would. But I think more the periaortics and things, it looks like they probably don't move, and you don't need to do 4D. But you would ever hate to miss the time when it does. And pelvic nodes, they don't move, but there's still other things that you need to consider, and one certainly is bladder filling instructions. So this is a case of 50-year-old oligometastatic RCC, and for some reason this was called, at simulation, this was called empty bladder, although it looks quite full to me. So you can see up in the cone beam this one day, they told her to empty her bladder. Well, there's the valve right in the high dose region. There it is. And on the, you can see the bladder's only filled to there, whereas it should be up to there. So something that's really important, and also important for the therapist to be able to be aware to assess. And the other, this is another abdominal node IGRT. It's just always looking at the organs at risk. I saw this cone beam after the fact, and one fraction would be okay, but the therapists were so happy with, oh, the target, it matched perfectly, everything is great, because you can see there's, you know, they had clips to look at. So it's hard to appreciate this, but I turn on what's the small bowel contour, so you can see that, but then you can also see this coming right through, which obviously wasn't contoured, means it wasn't accounted for in the plan. So there, you know, small bowel is very mobile. It's actually moved right in. So that's why I called it the sneaky small bowel. It's right into the target. And we assessed it for day 1, day 2, day 3. It kept being there. So it actually resulted the last 2 fractions to be recalculated for a lower dose to make sure it stayed. Yeah, it's also Dr. T's case. So the current is hard because nodes can be anywhere. So abdominal, we still put them in the body bag, but no compression. 4D, we're likely going to completely streamline our guidelines so that 4D is only done in those cases that we identify. Pelvic, again, no compression helical, and specify bladder status. The dose fractionation ranges from 30 to 40 and 5, and the PT margin is 5. And IGRT, again, is very similar to bone. Soft tissue to soft tissue. Those centrally located nodes tend to be, the bone match does actually really work. If you match the bones, you're going to be very close to the target, and it's helpful. And last, and this is going to be very quick, is pancreas, because pancreas is also very scary. So the pancreas challenge number 1 is just an anatomical one. So there it is, the duodenum, and we all know how radiosensitive it is. The duodenum wraps itself right around the pancreas. So that's challenge number 1. That's very difficult to overcome. Well, impossible, pretty much. Challenge number 2 for cone beam image guidance is, where is the pancreas? So yes, obviously I've put up a horrific cone beam to illustrate my point, but still, if you were going to do any sort of ablative doses, you can't with any certainty find pancreas there, which is why we were speaking when Dr. Wong was speaking, talking about needing fiducials. So we have begun a pancreas very slowly and very conservatively. So it started with locally advanced pancreatic cancer that's not resectable, and we also have treated some pancreatic mets. The initial immobilization was SBRT board and abdominal compression, and there was lots of sort of consensus that abdominal compression is not necessarily good in pancreas because you may actually bring the organs at risk even closer. Our original experience was with quite palliative patients, and we wanted to start with what we knew worked in terms of intrafraction motion. We knew that it would help manage the motion, so we went with what was comfortable. Also understanding this was not a population that we were going to be curing. So part of this is you need to be able to walk before you can run. So we started where we knew. We did 4D CT, 5 millimeter margin, and the patients must have had either a stent or an implanted fiducials in order to be treated. Otherwise, you just can't localize it accurately. We started with a 3 fraction because there was more, at that time, there was more data in the literature. We've since migrated to a 5 fraction. So when I also say this, we had a visiting professor come from MD Anderson who said, you shouldn't be doing that, you need to be doing this, this, and this. But part of it was, oh, you should do breath hold. I do voluntary breath hold. My patients can hold for 1 minute. We knew with our referral patterns, there was no way it was that. They also had variants. They could use the RPM system, which is very different. If we're doing breath hold, we have to do ABC, which is difficult on the patient. I adapt daily based on the cone beam. Well, he could review the cone beams from his computer. I'm like, we don't have that technology. So it's very much, you need to adopt all of your techniques to what your local technology can allow. So, well, this is why. Obviously, on these cone beams, you can be you can see at least the fiducials, but you can see the target in most not. So we do either match to the fiducials. I will say we still do not put fiducials in our liver. It's never something we have adopted because, well, William can say why, I don't know. Interventional radiology, they didn't want to do it for a long time. But for pancreas, you absolutely need something. And we did, this past Caro, Rachel Glicksman, who's one of the residents, did present our initial outcomes. Bear in mind, this was for our initial patient population was quite palliative, and sort of as we've gained experience, the surgeons have come more on board, and the referral patterns are changing, and now we're getting a few preoperative, we're getting, you know, it's starting to evolve, and with that, our technique will evolve. You know, patients don't do well with pancreas. This probably, if you looked at it, the local control or the outcomes are a little bit worse than what you see reported in the literature. I think the patient population is also not the same. Most of these patients did not have chemo. They obviously were unfit for surgery. So this was, you know, it's quite palliative in the beginning. It was really just to learn. The other is the possible toxicities. I say possible because a lot of them were likely due to progression. But it's still something you need to monitor what you're doing to see what your outcomes are or your potential toxicities. And another shameless plug. So the future hope, we all hope for pancreas SBRT is what the MR-Linac is going to bring us. So this is a picture of our MR-Linac team. You'll see one familiar face. But so pancreas is one of the sites that's sort of been identified. There has been studies from the View published, and they seem to be having very promising results. I mean, hopefully the idea is you're actually going to be able to see it. You'll be able to see the duodenum really well and maybe adapt on a daily basis to where the location of both of those are. I will say we're trying to, right now, we're moving away from abdominal compression, and we've been doing a lot of work in assessing the motion and any interfraction motion, and it's more just to try and take our current technique to a place that we can then transfer it to the MR-Linac. So, in conclusion, I think of, a strong, good for me, but it is true. A strong foundational SBRT program should be established before introducing less established sites. Again, I think you have to walk before you can run. Part of this, I often get site visits requests from people, and with emerging data for oligomets, people get very excited. We want to come see you. We want to grow our oligomets program. Okay, what are you treating now? Lung. Okay, lung to treating all of this is a big leap. There's a lot that has to be done and a lot of thought that needs to be put into it. And also, multidisciplinary collaboration is absolutely necessary for the safe, high delivery of high-quality SBRT. Certainly, the physics, our radoncs and our therapists do collaborate very closely in all of our sites of SBRT. And again, continuous evaluation of outcomes and the techniques is absolutely critical for the success of your program. And it's always great to look to do better than you are. And with that, I would just like to acknowledge the team. In particular, my two leaders, Ian Poon and Arjun Segal, and William Chu, because he's here, who's a great supporter of mine. So thank you, and I'm happy to take any questions because I think we have 4 minutes on the clock for the...